But more importantly, we then create bespoke digital health formularies. And the formulary is what is promoted to healthcare professionals. And what we do first of all is we train healthcare professionals. So the training is through the Digital Health Academy, which is both integrated and separate. So here in the UK, that's sponsored by another pharma group. So it's free to use for all NHS healthcare professionals.
And what are you training the healthcare professionals in? I mean,
It's basic learning. So it's about bringing the whole workforce up. And this isn't about helping champions. Champions are very well catered for. So we're training them in what is digital health, what are the opportunities, what are the barriers, and what do you need to think about if you're going to recommend a technology to your patients. So it's very basic. It's 2 45-minute modules.
Okay.
The CPD accredited. So that's promoted, that's about bringing the workforce up. Now, what we also have is then additional modules, which then a clinician can add on. So say, for example, if you're a GP with a specialist interest in diabetes, you would do the foundation modules and then you'd pick the diabetes module. And that diabetes module is talking through the pathway and which specific technologies have the best evidence for the best healthcare outcomes at certain points in that pathway.
that sounds smart. That's what we need.
Exactly.
Yeah.
It's got to replicate what happens in the world of medicine.
Yeah, exactly. And I've also been a speaker for us doctors seeing digital health as medicine, because they can actually harm people. And right now,
100%.
my patients are just using whatever their friends say or whatever they find on Facebook, and we don't have anything in Denmark that's regulated in any way, and we are not as doctors trained to recommend, and of course we can't prescribe in that way that we want to. But what I noticed is that my peers are recommending apps that they have personal experience with.
Exactly. And that is not necessarily clinically safe.
Oh no.
Because there's 2 elements to it. One is if you wave your phone at a patient, that's the equivalent of waving a box of medication at a patient and saying, go and buy that. The risk there is the patient then walks out and buys the wrong drug. Same thing with this. If I wave my phone at you and say, go and download app A, B, C, and you'd walk away and say, did you say app A, B, C, or was it app A, E, C? They might download the wrong technology. That's not safe. But also, even if you can feel that it's trusted today, what happens when it changes tomorrow?
Exactly.
And incorporates new risk. And so the formulary side of thing that we then create after the training is the prescription infrastructure. So doctors use Orcha powered formularies to recommend the best technology via text message or email to their patient. And here then we have strong risk management and a safe clinical system, because the system then has a record of what technology has gone to which patients. It's continuously reassessing the technology, and should a future fault be found, we can do a recall. And so strong governance is established. And then when you think about reimbursement, you can then feed reimbursement back in, because the system knows what's gone where and whether that person went on to download the technology. And so if you want to reimburse at scale, you can then reimburse. If you take something, you mentioned the DIGA. So the DIGA has been amazing. They've set up a framework, an assessment framework, and they've assessed some technologies. Now that's been quite slow, and the biggest challenge that they're going to have is they're going to have to reassess all those technologies again. So it's almost like you're back at square one. But the second thing is they've passed a law for reimbursement, but there's no infrastructure around deploying and activating healthcare professionals to then recommend the technology.
Do you have some numbers? Or I mean, it's, as you say, it's fantastic that you can actually draw data from the use of these things. Do you have some data on how many, for example, GPs are using or prescribing apps in this way? And
yeah. So we, in fact, there's a piece of research that I'll send you. We did a piece of research that was published in the BMJ, the British Medical Journal, about digital health trends during COVID, and how people, for a start, were searching for and looking for digital health technologies, how healthcare professionals engage with prescribing technologies and what the conversion rate was, and also how the innovators responded to the needs of people and patients.
Was it mainly like communication apps or?
So what we tend to see is it's a journey. So at the beginning of prescribing technology, medics and healthcare professionals are more interested in low complexity, high volume technologies. So wellness technologies, smoking cessation technologies, fitness tools, because they're lower risk. Then still nervous about using, say, a diagnostic, which is, it's obvious we're going to focus on low complexity, high volume. Where we probably want to shift that confidence to is high complexity, low volume, because there are some amazing technologies that could support, for example, the elective care recovery backlog. If you think about all the people that are waiting for a dermatologist to check whether their mole is cancerous, well, there are some great technologies that can help with that. And if we can build confidence in clinicians to recommend that, we can cut out a whole chunk of people who have had a mole that is okay and can now come off that waiting.
Absolutely.